Usually when we talk about human anatomy, there's this comforting expectation of mechanical predictability.
Right, like a textbook.
Exactly. We tend to view the body as a collection of simple machines. You have a pump, you have pipes, you have hinges, you bend your elbow, the bicep contracts, the arm goes up.
It's visible, it's logical, and it makes sense.
It makes total sense. But then you look at the clinical data surrounding the human pelvis, and that simple engineering manual it's thrown completely out the window.
Oh, absolutely.
Today, we're jumping into a deep dive on a stack of clinical notes, physical therapy guides, and medical journals that connect a totally common, often brushed off, and, well, sometimes embarrassing issue vaginal flatulence to a hidden electrical misfire deep inside your pelvis.
Yeah, and the mission for today's deep dive is highly specific. We are investigating whether pelvic nerve irritation can actually cause physical sensations of air trapping in the body.
Which is such a wild concept.
Yeah.
Because when we dive into these sources, we start to see that the body is essentially a highly complex and closed pressure system.
Right. And when the nerves that control the baseline tension of that system start to send faulty signals, the structural mechanics of the entire pelvic floor just go haywire.
So we have to stop looking at the body as just plumbing or hinges.
Exactly. We have to start looking at it as an electrical grid where, a single frayed wire can cause a system-wide mechanical failure.
Let's start with the symptom itself, because it's really the breadcrumb trail that leads us to this larger issue. Vaginal flatulence, often called queefing or vaginal wind.
Which is universally awkward, but rarely ever discussed seriously.
Right. Normally, this is just treated as a funny mishap in a yoga class or a totally standard part of physical intimacy. It's not something people typically rush to the doctor for.
No, they definitely don't.
But looking at these sources, chronic, unexplainable episodes of this happening constantly can actually signal that the body's internal electrical wiring is misfiring.
Yeah, and before we can understand how a nerve could possibly trap air, we have to look at the baseline physics of how air gets into the pelvic cavity to begin with.
Okay, let's unpack this.
Yes.
Because it's not like you're just breathing air into that space.
Right, exactly. From an anatomical perspective, the vagina is what is known as a potential space. It's not an open, rigid pipe like a hollow reed.
So it's not just sitting open.
No, not at all. In its resting state, the muscular walls are collapsed and resting against each other. Air only naturally enters when that potential space is physically opened.
Like during penetrative sex, or when a doctor uses a speculum during a gynecological exam.
Exactly. And it also happens purely through gravity. If your pelvis is elevated higher than your shoulders and the downward dog pose and yoga gravity pulls your internal abdominal organs downward towards your chest.
Oh, wow. So that organ shift creates a literal vacuum effect in the lower pelvis.
Yes, it pulls ambient air right into that potential space.
Which is just normal atmospheric pressure at work. The vacuum is created, the air rushes in to fill the void, and then when you stand back up and the pressure normalizes, the air gets pushed back out.
Right, it's just physics.
But wait, we always hear in health spaces that if someone is dealing with chronic, embarrassing vaginal wind, it's strictly a symptom of muscle weakness, like the pelvic floor is just loose.
Right, that's the conventional wisdom. The idea is that if the pelvic floor is loose and lax, the muscular opening just doesn't seal properly.
So air just flows in without resistance, and when you stand up or bend over, it escapes with a deep, audible sound.
But the clinical data completely upends that idea. The medical journals point out that a hyper-tight pelvic floor, one that's locked in a rigid spasm, is equally problematic.
Really, a tight pelvic floor.
Yeah, and in many cases, it's actually the primary driver of chronic air trapping. A rigidly tight pelvic floor effectively acts like a suction cup.
Are you saying a tight pelvic floor can actually act like a vacuum cleaner, just actively sucking air in?
Exactly. It alters the resting pressure of the cavity, actively drawing air into the vaginal folds. And then, because the muscular opening is so constricted and tense, it refuses to yield when the air needs to escape.
Oh, so it acts exactly like a whistle when that trapped air is finally forced out under pressure.
Yes, precisely.
I want to look closely at this case study published in the IOSR Journal of Nursing and Health Science, because it completely separates this issue from intimacy or typical postpartum weakness.
Oh, the pediatric case. That one is fascinating.
It really is. They documented a 10-year-old girl who had never been sexually active, who was suffering from constant, loud, involuntary vaginal noise. It was so severe and relentless that she was entirely avoiding school out of sheer embarrassment.
The diagnostic process for her is incredibly revealing. When the medical team finally performed a transperineal ultrasound, which is simply a wand placed against the outside of the perineum to look upward, they didn't find a weak, loose muscle structure.
What do they find?
They found a rectocele.
Okay, for someone who hasn't heard that term, what exactly is a rectocele doing mechanically inside the pelvis?
So a rectocele occurs when the supportive tissue between the rectum and the vagina weakens. This allows the front wall of the rectum to actually herniate or bulge forward into the back wall of the vaginal cavity.
Oh, I see. So that physical bulge completely alters the interior architecture.
Exactly. It changes the volume of that potential space we talked about earlier. By pushing into the cavity, it creates irregular pockets and drastically alters the intra-abdominal pressure dynamic.
That makes sense. The crucial takeaway from this pediatric case is that severe chronic air trapping is driven by anatomical pressure imbalances and structural shifts. Right. Not just a loose muscle from childbirth.
Right, exactly.
So if we apply that logic to a tight muscle, it completely reframes the conversation. We hear pelvic floor issues and automatically assume we need to tighten things up.
Which is often the exact wrong move.
But you're describing a scenario where a hyper-tight muscle behaves like a vacuum cleaner, actively sucking air in and refusing to let it go. How does a muscle being too strong cause it to lose control of air?
Well, the paradox here is that hypertonic muscles locked in an overactive rigid state, are fundamentally weak. They lack dynamic coordination.
So they're strong in a static way, but useless in motion.
Exactly. A healthy, fully functional pelvic floor operates like a trampoline that synchronizes perfectly with your diaphragm.
Oh, I like that analogy.
Yeah, so as you inhale, your diaphragm expands downward into your abdomen. To accommodate that downward pressure, your pelvic floor must naturally yield and drop slightly.
And as you exhale, the diaphragm moves back up, and the pelvic floor recoils to its resting position.
Right. That harmonious, coordinated piston effect naturally and silently releases any tiny amounts of ambient air that might have entered.
But if that trampoline is pulled completely taut and turned into a sheet of rigid concrete, it just can't absorb the downward pressure.
Precisely. It does the opposite of yielding. It stays fiercely clenched. So when the diaphragm descends during a breath or a movement, the abdominal pressure spikes, but the rigid floor refuses to drop.
And that creates a high-pressure trap.
Yes. The rigid muscles hold the air inside until the internal pressure mounts so high that it violently overcomes the muscular resistance, forcing the air out audibly.
Okay, so if a rigid, uncoordinated pelvic floor creates this suction cup effect, what is causing the muscles to lock into this aggressive, permanent state of tension to begin with?
That is the million-dollar question.
Right, because muscles usually don't just cramp indefinitely for no reason. And this is where the clinical notes point us away from the muscles entirely and direct us toward the nervous system.
Yes, specifically, we have to look at the master control wire for the entire region, the pudendal nerve.
Let's talk about the pudendal nerve. Where exactly is it?
So it's the primary electrical trunk line for the lower pelvis. It originates from the sacral nerve roots, specifically at the S2, S3, and S4 levels near your tailbone.
Right, deep in the back of the pelvis.
Exactly. And from that origin point, it has to navigate a highly tortuous, hazardous path through the deep structures of the pelvis before dividing into 3 branches.
And those branches are the inferior rectal, the perineal, and the dorsal coloral or penile nerves, right?
You got it. It governs both movement and sensory feedback for the genitals, the perineum, the anus, and the surrounding muscular slings.
That journey through the pelvis sounds like an anatomical hazard zone. So if the pudendal nerve is the electrical wire, its path through the pelvis sounds like routing a power cable through a pair of scissors.
What's fascinating here is that the anatomy really is incredibly unforgiving. As the nerve travels downward from the sacrum, it must weave its way between 2 massive, dense bands of connective tissue.
The sacrospinous and sacrotuberous ligaments, right?
Exactly. These ligaments are crucial for stabilizing our pelvis when we walk or run. But because of their position, they essentially form a biological lobster claw around the nerve.
A lobster claw. That sounds painful.
It is. If your biomechanics are slightly off, or if you sustain a trauma, those ligaments can shear against each other, physically crushing the pudendal nerve between them.
Just literally pinching the nerve. And even if the nerve makes it past those ligaments without getting pinched, the sources say it then has to travel through something called Alcock's canal.
Right. Alcock's canal is a tight, tunnel-like sheath of fascia that runs along the inner wall of the pelvis. It's right alongside a major hip rotator called the obturator internus muscle.
So if that muscle gets tight like from clenching your glutes all day at a desk or aggressive training, it swells up.
Yes, it swells and compresses Alcock's canal. This direct friction and strangulation of the nerve leads to a condition called pudendal neuralgia, or pudendal nerve entrapment.
Sometimes called cyclist syndrome in sports medicine.
Exactly.
The clinical descriptions of the pain associated with pudendal neuralgia are absolutely brutal. Patients report sharp, burning, or electric shock-like nerve pain.
Yeah, it's severe.
But the most defining hallmark symptom across all these medical sources is a highly specific positional trigger. The pain becomes agonizing when the person is sitting down, but is mysteriously relieved when they stand up, or specifically, when they sit on a toilet seat.
The physics of the toilet seat actually offer a perfect diagnostic clue.
Really? How so?
Well, when you sit on a standard, flat chair, your body weight compresses the tissues of your buttocks and perineum upward. This directly mashes that already inflamed pudendal nerve against the pelvic bones and ligaments.
Oh, ouch. But a toilet seat is different.
Exactly. When you sit on a toilet, your ischial tuberosities, your sit bones, take all the weight on the rim. Meanwhile, the entire center of your pelvic floor is suspended over the open bowl.
So there's zero upward compressive force on the nerve.
Precisely. It completely unloads the nerve.
That makes so much sense. But this brings us back to the core mystery of the ear trapping. If this nerve is being crushed inside a tunnel or pinched by a lobster claw, how does that translate to the physical sensation of trapped air?
According to the research, this is where the nervous system essentially starts hallucinating. The inflamed nerve causes a bizarre neurological glitch known as a foreign body sensation.
A foreign body sensation, like feeling something is in there.
Yeah. Because the nerve is damaged or severely irritated, it loses its ability to transmit clean sensory data. Instead, it blasts the brain with corrupted, static-filled signals.
And the brain just misinterprets that static.
Exactly. The brain attempts to interpret this chaotic static and often translates it into the sensation of a physical object. Patients frequently report feeling as though there is a golf ball, a hot poker, or a pine cone permanently lodged inside their rectum or vagina.
A pine cone. That sounds psychologically torturous, feeling like there's a golf ball inside of you, but knowing intellectually there's nothing there.
It really is. And it's crucial to note that this condition affects men too. Men with pudendal neuralgia experience painful erections, ejaculations, and that exact same golf ball sensation in the rectum.
Here's where it gets really interesting, though. So for the listener, how do they know if the pressure they feel is a phantom golf ball created by a misfiring nerve or actual trapped air causing vaginal flatulence?
Well, it's often a vicious cycle of both. The transition from a sensory illusion to a physical reality is a fascinating defensive mechanism.
So the body is trying to protect itself.
Yes. The brain is receiving a screaming alarm from the pudendal nerve, insisting that a foreign object, the phantom golf ball, is intruding into the pelvis. In response to what it perceives as an attack, the central nervous system commands the pelvic floor muscles to aggressively clamp down and guard the area.
Ah, so that subconscious, unrelenting muscle spasm is what fundamentally alters the pressure gradient we discussed earlier.
Exactly. The guarding muscles turn the vaginal cavity into a rigid vacuum chamber, pulling actual pockets of ambient air inside.
And then the trapped air presses outward against the vaginal walls, physically pushing against the tissues surrounding that already hypersensitive, inflamed pudendal nerve.
Which triggers an entirely new wave of pain signals to the brain, prompting the muscles to clamp down even harder.
Wow, it is a devastating neuromuscular feedback loop. The neurological illusion commands a physical muscular reaction, which actively creates the mechanical pressure issue.
It's a perfect storm.
And the activities that trigger this initial nerve irritation are astonishingly common. Everyone assumes pelvic dysfunction stems from childbirth, but the clinical literature lists triggers that are simply normal parts of life.
Oh, absolutely. Prolonged sitting is a huge one.
Which is how most of us work. And then there's aggressive cycling, motocross, heavy lifting routines involving deep squats, falling hard onto your tailbone, or even complications from pelvic mesh surgeries.
Right. We're looking at cumulative microtraumas. Spending hours crouched over a road bike systematically compresses the nerve against the saddle.
Or heavy squats spiking that intra-abdominal pressure.
Exactly. Forcing the pelvic floor to bear down forcefully while the surrounding hip muscles fatigue and tighten. Over time, those repetitive stressors thicken the fascia and tighten the ligaments.
Slowly closing that lobster claw around the nerve. With a feedback loop this complex, getting a proper diagnosis seems like a massive hurdle.
It's incredibly difficult. The literature shows that misdiagnosis is incredibly prevalent.
I mean, patients often spend years bouncing between specialists, right? Being told they have interstitial cystitis, which is painful bladder syndrome, or endometriosis, or irritable bowel syndrome.
Yeah, they're chasing treatments for their bladder or their gut when those organs are actually perfectly healthy.
So why does it feel like a bladder or gut issue?
The confusion stems from the branching nature of the pudendal nerve. Because the nerve supplies the entire region, if the specific branch running near the bladder is pinched back at the ligament, the brain registers the pain as coming from the bladder.
Oh, that makes sense. To cut through that confusion, neurologists and specialized doctors rely on a diagnostic framework called the Nantes criteria. How does a doctor definitively prove it's a misfiring nerve?
Well, the Nantes criteria establish 5 non-negotiable benchmarks. First, the pain must be located strictly within the anatomical territory of the pudendal nerve.
Okay, that's straightforward.
Second, the pain must be noticeably worse when sitting, for the compressive reasons we discussed. Third, the pain typically does not wake the patient from a deep sleep at night.
Because when you're lying flat, gravity isn't compressing your organs downward and your sit bones aren't pressing upward, relieving the load on the nerve.
Right. The fourth criterion notes there should be no superficial sensory loss. You can still feel a pinprick on the skin, it's just transmitting hyperpain.
And the fifth is that the pain must be temporarily erased by a diagnostic pudendal nerve block.
Yes. They also check for the Valeix phenomenon.
Valeix phenomenon, what's that?
That's where the physician applies direct internal pressure along the physical path of the nerve. If pressing the tunnel triggers the exact golf ball sensation, they know they have found the precise point of entrapment.
Wow. And once the diagnosis is confirmed, we hit the most critical warning found in all of these physical therapy guidelines. It involves a fundamental error in how we approach pelvic health.
Yes, the default reliance on Kegel exercises.
We hear this constantly. Magazines, doctors, postpartum guides. The universal advice for anything related to pelvis is do your Kegels.
Which is terrible advice for this condition.
If you're leaking, do Kegels. If you have vaginal wind, do Kegels. But for someone with pudendal neuralgia, doing a Kegel is like tightening a knot that's already stuck.
If we connect this to the bigger picture, applying Kegels to pudendal neuralgia is akin to pouring gasoline on a fire.
Seriously, it's that bad.
Yes. A Kegel is a concentric muscle contraction. It's a conscious, forceful tightening and lifting of the pelvic floor.
So if a patient's pelvic muscles are already locked in a rigid hypertonic spasm that is actively crushing their pudendal nerve.
Exactly. Commanding them to voluntarily squeeze those muscles even tighter will dramatically amplify the nerve compression. It tightens the lobster claw, exacerbates the pain, and locks even more air inside the vacuum.
That is just wild. Treating a tight spasming muscle like a weak, flaccid muscle seems like the ultimate trap. It completely validates why someone might do months of physical therapy and actually get much worse.
It happens all the time.
So if strengthening is off the table, the actual clinical treatment must focus entirely on downregulation and relaxation.
Right. The primary objective of specialized pelvic physical therapy is to lengthen, soften, and restore elasticity to the tissue. The foundation of this is diaphragmatic breathing.
Breathing exercises. How does that help the nerve?
Well, patients have to retrain their nervous system to allow the pelvic floor to physically drop and expand downward on the inhale. They have to break the habit of subconsciously sucking the stomach and pelvic floor up and in.
The physical therapy notes also mention specific postural work, like integrating yoga poses such as the cobra pose to actively stretch the abdominal wall. But for structural management, some gynecologists recommend using a vaginal pessary.
Which can be a game changer for some patients.
It sounds so counterintuitive to me. If the area is already irritated, how does inserting a physical device help stop the feeling of trapped air?
I know, it sounds backwards. But a pessary functions as a structural buffer. By occupying the muscular opening at the base of the pelvis, it physically fills that potential space we discussed at the beginning.
Oh, so it acts like a placeholder.
Exactly. By occupying the space, it stabilizes the surrounding tissue and prevents the rapid, vacuum-like influx of ambient air.
It removes the mechanical fluctuation of air pressure, giving the hypersensitive nerve a chance to calm down without constantly being pressed against by trapped pockets of wind.
Right. It stops the physical movement of the tissue.
But for the more severe cases where breathing exercises and structural buffers just aren't enough, the medical interventions have to get far more aggressive, right?
Mm.
The clinical sources detail using targeted Botox injections directly into the pelvic floor muscles.
Yeah, and Botox is highly effective here because of its mechanism of action. Botulinum toxin chemically blocks the communication at the neuromuscular junction.
So it cuts the communication line between the screaming nerve and the guarding muscle.
Precisely. By chemically forcing the muscle to stop spasming and relax, you open up Alcock's canal and relieve the pressure on the pudendal nerve, breaking that vicious feedback loop.
Alongside Botox, doctors utilize repeated targeted nerve blocks, injecting anesthetic and steroids directly around the nerve to quiet the inflammation.
And if imaging shows that the nerve is physically tethered, glued down by scar tissue, or permanently trapped by the ligaments, surgical decompression becomes the final option.
So surgeons actually go in and carefully sever the restrictive ligaments to set the nerve free.
Yes, the clinical pathway is always progressive. You start with behavioral adjustments like investing in a standing desk or using a specialized suspension cushion for sitting.
Then you move into specialized relaxation-focused physical therapy.
And you escalate to injections or surgical decompression only if the conservative measures fail. But success entirely depends on recognizing that the muscles and the nerves are locked in a dysfunctional, miscommunicating dance.
It's just a remarkable progression of understanding. We started today by looking at a totally common, often dismissed mechanical annoyance like vaginal flatulence.
Queefing.
Right. But by following the physical symptoms, we uncovered a complex electrical failure involving the pudendal nerve. The nerve gets crushed, it sends a panic signal to the brain, the muscles clamp down in defense, that spasm creates a vacuum, and the vacuum traps air.
All while the brain hallucinates the sensation of a golf ball.
Exactly. It highlights the vital importance of looking past the superficial symptom.
When you understand the underlying mechanics, how the pressure gradients interact with the electrical grid, the seemingly bizarre symptoms make perfect physiological sense.
So, to you listening, if you are dealing with chronic, unexplainable pelvic sensations, pay attention to the positional clues.
Yes, the clues are everything.
If you feel that phantom golf ball, or if you have severe burning pain that aggressively flares up the moment you sit down at your desk, but vanishes when you sit on a toilet seat, do not accept a brush-off.
Don't settle for someone telling you it's all in your head.
Or just handing you a pamphlet on Kegel exercises. You now understand the mechanics of the lobster claw. You know how the pudendal nerve operates.
The burden often falls on the patient to advocate for themselves. Finding a specialist who comprehends the neuromuscular electrical wiring of the pelvis, rather than just treating the muscular plumbing, is the absolute key to recovery.
I want to leave you with a final thought to mull over. We've just spent this time exploring how one single microscopic pinched nerve deep inside the pelvis can generate the phantom sensation of a golf ball, or literally command your internal musculature to act as an active vacuum.
It really makes you think.
It really does. It makes you wonder. What other frustrating, chronic, unexplained bodily sensations, perhaps a lingering ache in your shoulder, a sudden phantom chill, or a heavy numbness in a limb, might not be a structural injury at all, but rather our nervous system playing a masterful, invisible trick on our anatomy? Keep questioning what you feel. Thanks for diving deep into the sources with us.